Hello friends, welcome to the series of Me and My Hysteroscope. All of us know that the amazing art of hysteroscopy has evolved recently, but behind that there are incessant efforts of our scientists. So, Me and My Hysteroscope enter the uterine cavity with lots of gratitude and respect. Thankful to the brains who worked hard, created designs, spending sleepless nights with untiring efforts. Adoring the hands who meticulously manufactured the instruments and gadgets. Admiring the brain and hands that operate simultaneously and skillfully. Creating miracles so much, giving almighty touch. Namaskar. Today I am introducing you a very affectionate and angelic personality from Bologna, Italy. That is Dr Giampietro Gubbini. He is the person with loving heart. He loves the people, friends, and they love him. He loves hysteroscope. So the hysteroscope loves him and obeys his order. He has many honors in his credit. Currently he is working at Casa di Cura Madre Medical Center. He is a renowned faculty of the world and is involved in many academic activities. His main landmark work is his own design, Gubbini's Miniresectoscope. His areas of interest are Isthmocele and submucous myoma. Hysteroscopy plays a wonder role with his gifted and skilled hands. Dear friends, work with affectionate and loving heart. The blessings will follow you. Welcome Dr. Giampietro Gubbini in this world of hysteroscopy.
Hello my dear Sushma and good morning my friends, Hysteroscopist friends. Bye bye from Bologna, Italy. Ciao.
Thank you Dr. Gubbini. So friends, today we are going to learn one important condition from Dr. Gubbini, that is Isthmocele. We know that Isthmocele is a reservoir-like pouch defect on the anterior wall of uterus at isthmus at the site of previous cesarean delivery scar. Now the question is that how you suspect Isthmocele? This interview will be slightly different. Dr. Gubbini would like to show you his video and his techniques.
Isthmocele is often detected incidentally in patients presenting with clinical symptoms such as post-menstrual spotting, dysmenorrhea, dyspareunia, infertility, chronic pelvic pain, or dull sensation following menstruation.
So friends, you can suspect Isthmocele by the patient's complaints and confirm with the help of ultrasound in the sagittal view of the uterus. And you can appreciate an anechoic area like a triangle with the apex pointing towards the anterior wall of isthmus and the base directed towards the posterior wall of cervical canal. With the help of hysteroscopy, we can diagnose the Isthmocele as well as we can plan treatment for it. Dr. Gubbini has developed channel-like treatment for Isthmocele. Let's know the basic principle of it.
Isthmocele channel-like treatment points on the resection of the inferior and superior edges of the defect, placing its wall in continuity to that of the cervical canal. We also performed 360-degree endocervical ablation, removing all the inflamed and fibrotic tissue in the cervical canal.
Dr. Gubbini has designed Gubbini's Miniresectoscope. Dr. Gubbini, we'd like to see your workplace and also would like to know your instrument.
This is my operating room. This is my Miniresectoscope.
Wonderful place. I had been to this place and I just worshipped this place. This place has become pious due to godly presence of Dr. Gubbini. And you know, Dr. Gubbini gives channel like 360 degrees Isthmocele treatment with his 16 French Miniresectoscope, step by step without cervical dilatation. Let's see how it works.
Our objective is to describe hysteroscopic isthmoplasty performed without cervical dilation with Gubbini 16 French Miniresectoscope, with the aim of showing step by step our proposal of standardized surgical technique. Before starting the procedure, the bladder was filled with methylene blue solution to allow early identification of bladder injuries. Dense and viscous mucus-like material and brown blood were found in the niche. Its persistence after menstruation may contribute to postmenstrual abnormal uterine bleeding. Cesarean scar defect was localized and depth of the niche was evaluated with the loop. The small diameter of 16 French resectoscope and the use of miniaturized circular loop without cervical dilation make this kind of isthmoplasty safer, even if the myometrial free margin above the niche is very thin.
Just super. Now enjoy this amazing technique.
Step 1. Resection of proximal edge. First, high-frequency 90-degree angled circular loop electrode and pure cutting current of 100 watts were used to resect completely the fibrotic tissue of niche's proximal edge, modulating the technique on the ground of the defect site. At this level, we performed resection not only of the fibrotic tissue underneath the niche, but also of the inflamed tissue placed around the niche and on the opposite side. The so-called channel-like 360-degree endocervical ablation. 16 French miniaturized resectoscope has an outer diameter of the sheets of nearly 5 mm, the same diameter of office hysteroscope. This small diameter allows operative procedures to be performed without cervical dilation, so without anatomical distortion of the defect, and reducing the risk of complications. The small diameter of the sheets also makes surgical gesture faster. The removal of tissue fragments is easier, with easier and faster approach to the niche compared with Isthmocele hysteroscopic standard surgery. Step 2. Resection of distal edge. Circular cutting loop was used to resect completely the fibrotic tissue of niche's distal edge, with the same technique showed in the first step. The surgical movement during step 2 goes from isthmus internal orifice toward niche area. Even at this level, we also removed the inflamed tissue placed around the niche and on the opposite side. In this way, 360-degree endocervical ablation was completed. Several clinical studies reported high success rates in terms of resolution of symptoms and pregnancy after hysteroscopic isthmoplasty. However, these findings have not been confirmed in randomized controlled trials. Hysteroscopic isthmoplasty has low operation time and it can be performed in day surgery. Persistence of symptoms has been reported in up to 18% of cases, so we always perform adequate counselling before the procedure. If surgery fails, it is possible to try with a second surgical attempt or with medical therapy, consisting of topic or systemic progesterone. Step 3. High-frequency angled ball electrode was used to obtain focused coagulation of all residual inflamed tissue still present on the niche surface and on the cervical canal walls. The aim of this step is to facilitate the re-epithelialization of cervical canal walls by paraphysiological endocervical epithelium. Step 4. Bleeding control. Isthmoplasty was ended by focused electrocauterization with ball electrode of bleeding endocervical vessels. Reduction of inflow and pressure of the distending medium can help to find bleeding vessels. After removal of niche's edges by this channel-like technique, the walls of the niche are in continuity with the cervical canal and the uterine cavity, allowing the normal flow of menstrual blood through the cervix that was previously slowed by the presence of the Isthmocele niche. The result of this technique is also the resection of all the inflamed tissue around the cesarean scar defect.
Now lastly, what is your message to hysto lovers?
My friend, please learn and love hysteroscopy.
Thank you very much, Dr. Giampietro Gubbini. So friends, here we end our session. But always remember, you have to think hysteroscopy in patients with chronic pelvic pain, irregular bleeding PV, infertility, and always remember the conditions like Isthmocele. Thank you.